Hello everyone, I am Dr. Bhaskar Debnath, Honorary Register in the Care of Elderly Department in Meadow Maritime Hospital. I am going to present my poster, Compliance with Nutritional Assessment Guideline and its Impact in Older Adults with Neck of Femur Fractures. On background, I am going to talk regarding sarcopenia, which is defined as a loss of muscle mass and muscle strength. Sarcopenia presents in a large group of patients with neck of femur fracture. Management of sarcopenia has a specific guidance and it includes completion of MAST score, our topic of focus in this project. There is convincing evidence showing that nutritional status, frailty, and sarcopenia are interrelated, and prioritizing nutrition can reduce the disease burden in these other areas. MAST score means malnutrition universal screening tool. It is calculated by adding up three scores: BMI score, percentage of weight loss score, disease effect scores. The highest score can be 6 and lowest is 0. Score 0 means low risk of malnutrition, where 1 means medium and 2 or above means high risk of malnutrition. So it identifies adults at risk of malnutrition and helps guide nutrition care plan. Aim and objectives. Our aim and objectives were to review if MAST scores were completed within 24 hours of admission, to identify if the appropriate management for each calculated MAST score was actioned, to identify whether these guidelines have a clinical impact on patient's outcome using clinical frailty score and time to medically fit of a patient from admission and their clinical correlation with MAST scoring. We included the patient with neck of femur fractures, age more than 65 years of old, and admission lasting more than 1 week, and patients not on end-of-life care pathway. We excluded the patient who did not present with neck of femur fracture, admission lasting less than 1 week, patient less than 65 years of age, and we also excluded the patients who had pathological fracture, that means fracture from primary or metastatic bone malignancy, patients of palliative care or end-of-life care, and also patients readmission for the same fracture episodes or patient transfer from the other hospitals after operation. Methodology: patient identifiable information copied into an Excel spreadsheet, then patient flowchart accessed after 24 hours of admission to ascertain if a MAST score had been calculated within 24 hours. And once MAST score had been calculated, we noted whether appropriate management has been actioned. And we also noted clinical frailty score during admission and time to be medically fit were fit, and it was calculated and noted in the Excel spreadsheet. This was then correlated with MAST scoring. Results: in our first audit, 55% patients were female and only 42% were male. And in second audit, 69% were female and only 35% were male. Then regarding MAST scoring, uh, in first audit there are total 40 patients. Among 40 patients, 27 had MAST score of 0, 5 MAST score of 1, and 8 patients had MAST score of 2 or above. In our second audit, among 65 patients, 49 patients had MAST score 0, and 5 had score 1, and 9 had score 2 or above. Then we see that whether this MAST scores was taken within 24 hours. In our first audit, we found that 83% of patients' MAST score were not calculated within 24 hours. That improved significantly in our second audit, and we found that 97% of patients' MAST score was taken within 24 hours. After that, we see that whether treatment based on MAST score was actioned. In our first audit, only 32% cases MAST score was actioned. That declined in our second audit. We found that only 19% of the patients management was actioned depending on the MAST score. Then we did a simple correlation between MAST score and length of stay to be medically fit and MAST score with clinical frailty score. And we found that there was a simple correlation presented between MAST score and length of stay to be medically fit for discharge, and also between MAST score and clinical frailty score. Even though due to small sample size, the correlation was not significant. Discussion. Although calculation MAST score on admission has improved, but the patient with high scores are not consistently receiving appropriate care and management within 24 hours of admission. A correlation between MAST score and clinical frailty score was observed, but it was not clinically significant. The limitation was a small sample size, and in conclusion, The audit highlighted poor compliance with the 24 hours must score requirement, which may adversely affect patient outcome given its link to higher morbidity and mortality. Education of nursing staff and the wider MDT is recommended, with physiotherapy progress assessment incorporated to provide further insight. A re-audit is advised to evaluate the impact of these interventions. Thank you.